So good morning, everyone, and thank you so much for joining us here today at the CBD Expo Mountain. My name is Christina Etter, and I am the editorial content director for a publication called Cannabis Tech. We cover the science and technology behind the scenes in the cannabis and hemp industries. Although I spent 20 years working in corporate mobile technology, I can't say that I ever imagined that I would be employed by a cannabis publication, or for that matter, standing here with all of you talking about the opioid epidemic that's gripping our nation. But just a few years ago, my life changed. For years, I watched my husband struggle every single day with the concoction of massive doses of opioids, including Vicodin, fentanyl, and Percocet. I listened to one physician after another in 2 different states tell us that opiates would always be a part of his pain management regimen. But then in March of 2016, I watched something amazing. I watched my husband walk away from a 10-year legal opiate addiction without so much as a single day of withdrawal. I was absolutely amazed by what I had witnessed and by what he experienced. And I knew that I had to tell the world what we had seen. If CBD and cannabis products could do this for my husband, I knew that they could help someone else too. And that's when I switched careers and I became a journalist in the cannabis industry. Today, I cannot tell you the honor that it is for me to stand up here and host this panel talking about this topic that is absolutely tearing our country apart and leaving behind grave consequences. Let me bring you up to speed. Just last month, the Department of Justice released a report about the current state of the opioid epidemic after doing an investigation. And although we saw a decline in overdose deaths in 2018, there's still a lot of work that needs to be done. More than 67,000 people still lost their lives. We have a long way to go. But let me read you a little excerpt from the report from the Department of Justice. We found that the rate of opioid overdose deaths in the United States grew on average by 8% per year from 1999 until 2013, and then by 71% per year from 2013 to 2017. Yet from 2003 to 2013, the DEA ramped up their production of opioids. And it wasn't until 2017 that they did anything to reduce the production of OxyContin. Yet, despite the 77-page report that was released by the Department of Justice, not once did they mention anything about research into alternatives. It was all about law enforcement and better data tracking. So while the government is wrapped up in production quotas, people are suffering and they don't have any alternatives and they're left to fend for themselves. Today we have this incredible panel of experts that is here to talk to us about how CBD could be that key to opening up the door for this opioid epidemic and help to avert the crisis. Please welcome to our panel today Dr. Julian Grove, Dr. Christian Shaw, and Dr. Dexter Russell. Thank you. Now we're going to start this off real quick. If each of you would like to go through, and we'll start with you, Dr. Grove, and just tell us a little bit about your background and what your experience is.
Sure, absolutely. And thanks for everyone for coming out today. It's a very important topic and wonderful introduction. It's the introduction that you have is not uncommon that I hear in the pain management world in terms of a loved one, a spouse, a child that is affected with the opioid crisis in some way, shape, or form. So it gets very personal and emotional, and appreciate your energy. I think it's well directed. Again, my name is Dr. Julian Grove. I'm a board-certified anesthesiologist and pain specialist. I did high school at Smoky Hill in Aurora, nearby, and medical school here at the University of Colorado. I went out to Stanford University for my anesthesiology training and out to Harvard for my pain medicine fellowship. That was in 2004. I've been in Louisiana for 2 years and then practicing in the Phoenix metro area since 2007. I am in a group that has 3 clinics in Phoenix, Scottsdale, and Chandler in Arizona. We have 7 providers, see about 40,000 patient visits per year. My day is broken up between 50% interventional therapies for pain and 50% medical management of pain syndromes. That can range from spine-related issues is probably 2/3 of what I see, to complex headache, complex rheumatologic issues, cancer pain, and end-of-life pain, to mention a few. I would say I'm a traditional pain management physician in the sense that when I finished my training in 2004, opioid prescribing was in full swing. I have 3 of the 7 attendings that taught me at Harvard were on boards of all the 3 different pain journals, the 3 biggest pain journals, and they were, and opioid prescribing was definitely a big thing. At that stage, there was a lot of patients who were on OxyContin that were getting switched to the fentanyl patch or another long-acting opioid medication, but the mantra was still that long-acting opioid pain medication was safer than short-acting medications, and I think we've seen certainly in the ensuing decade that there's been a false narrative to some degree. Now, I'll say that I still prescribe opioids. I think judiciously and reasonably we need opioids for acute care, for chronic care, for end-of-life care. I think they have their niche. But I'll be the first to say there's a lot of finger pointing to be done in the last decade or two regarding the opioid crisis, and irresponsible prescribing and inappropriate prescribing is part of the picture. Fast forward about 2 or 3 or 4 years ago, we started having a few patients anecdotally tell myself and the 2 other partners at our clinic about CBD use and or THC use for voluntarily reducing their opioid load. And it's a complex issue because I'm sure Dr. Shaw and Dr. Russell will mention too, is that many patients at a certain level of opioids where they start to, where they get benefit, after a year or 2 or 3 down the road, they develop tolerance to that opioid. And you can either increase that opioid or you can decide to switch to another type of modality. That second part is difficult in the sense that we don't have great medicines in order to come off opioids. Each and every one is either a substitution for a different type of opioid that may or may not have a safer profile, and or coming down on adjuvant medications. And those adjuvant medications all have their own side effect profile: skeletal muscle relaxers, cognitive sedation, anti-inflammatories, kidney and cardiovascular issues, and neuropathic medications, also some cognitive issues too. So CBD and THC fit a mold that they seemingly, and I'll specifically talk about CBD, had a very low to negligible side effect profile. No really cognitive effect at all. So at 2 or 3 years ago, myself and Dr. Kubitz, my partner, we ended up delving into this and forming a CBD company. I'll not take any more time other than to say that the past year and a half we've been collecting data. I've presented at 3 of the biggest pain management conferences. I'll be at American Society for Regional Anesthesia and Pain in November. We're presenting at the Mayo Clinic Conference in California in 2 weeks. And then our data is going to be published through 2 University of Arizona researchers, hopefully winter or spring, in regards to CBD. Specifically, what I've done is a year-long data set on patients who have complex pain issues, reduce their opioids by use specifically of CBD. And it's pretty compelling data. It's approximately 56% of patients reducing their opioid load by 50%, and 15 to 20% entirely reducing their opioids. And that's just after a year. We have some patients who are continuing on that paradigm and doing well with slow reduction. But I'm a huge advocate of CBD in the medical field and its use in the medical field. We're parsing out side effects and dosing. But I'm a physician who is embracing CBD and finding it as an excellent niche in the chronic pain population. And partially the addiction population. I'll let Dr. Shaw expand on that as his specialty. But that's about it for me. Thank you.
Thank you. Dr. Shaw?
Hi, good morning. I'm Dr. Shaw. My focus really involves addiction treatment. I trained as a physician and a neuroscientist, then specialized in preventive and occupational medicine. in New Mexico, and at the time, that state had a generational heroin problem, so I got interested in kind of looking more into the treatment of opiate dependence. So later focused my training on that and subspecialized in addiction medicine. I'm the medical director of 2 opioid treatment programs, one in New Mexico and one we've opened in Indiana. I kind of try to go where the action is, and in the Midwest is getting crushed right now with opiate use disorder. Like others, I came upon cannabidiol years ago when I was in training and just started to follow it over the years. More recently, I have been conducting my own case studies on patients, really just determine if the hype was true, and found similar results as Dr. Grove, although I only focused on a patient that I thought if it was going to work, it's going to work on this. I'll use very high dose CBD isolate only on a patient who had multiple autoimmune disorders. So I treated her with 600 milligrams of CBD dose, 200 milligrams daily for a month. I took, then I wanted to also demonstrate from a biochemical perspective, so I drew her blood before the treatment started to look at her inflammatory markers. After the 28-day process, drew her blood again and was able to show biochemically, in fact, that she had a reduction in 2 kind of generic biomarkers, CRP and ESR. I also had her complete pre- and post-treatment pain scales from McGill that are pretty extensive but well validated, as well as what's called SF-36 quality of life assessment that a lot of governments and big insurance companies use to really evaluate should we implement this kind of treatment, purchase this type of medication, et cetera. So that's in the process of being published, so I'm pretty excited that I think there's going to be a lot of evidence rolling out in the future to the effectiveness of cannabidiol, and most likely the whole spectrum and interplay of cannabinoids with terpenes, et cetera. So I'll pass it on to Dr. Russell.
Good morning, everyone. My name is Dr. Dexter Russell. I'm a naturopath, and I doubt if anyone in here, except for a couple of my colleagues up here, naturopathy is a form of manual medicine. What I do, I specialize in musculoskeletal issues. I usually see people before Dr. Groves because they come to me for like sciatic pain, injuries that are acute that can evolve into a more chronic condition. And so through manipulation of the physical body, I'm able to create and increase people's range of motion, more importantly, identifying structures in the body that is creating nerve compression, which result in pain and inflammation. Now, you probably hear a little accent in my voice, right? So I gotta fess up. I'm from Jamaica. And growing up as a child, where I'd go to the country every summer, and lo and behold, the first thing I got when I went to visit my relatives was a cup of ganja tea. Now, full disclosure, I didn't get high. However, there's a subculture in Jamaica called the Rastafarians. And for years, they've been preaching about the benefits of ganja, marijuana. And of course, growing up, I wasn't drawn to it. However, it was compelling when you listen to the lyrics of people like my neighbor, Bob Marley, Peter Tosh, and these people were brutalized for just talking about a natural plant, and that confused me. I just couldn't see the dangers or the evilness as they would describe it. It was actually used to control a segment of the population. The laws were passed to keep people wherever you were, keep you in check. Well, with my growing up in that environment, it never left me when I saw the brutality that was inflicted on people for smoking what we call a spliff. And that just didn't sit right with me. Well, fast forward, I'm now in the medical field, And I'm treating people for pain, which a lot of it has to do with lifestyle. A lot of it has to do with sitting all day. And so these conditions are showing up. And people will come to me and they say, first of all, I get phone calls every day. They want to come in. A short interview on the phone, they're shopping for opioids, which I can't prescribe. However, when they do come in and I'm able to talk to them over time, I found out with some of what I do, what I'm trained to do, plus what I encourage them to do in terms of physical activity, moving about, diets, rest. There's a shift in the mindset. When I know that when that occurs, then I bring them back to the plant itself. Cannabis is here for a purpose and a reason. We have evolved with it. The plant is constantly changing, and so we have to change with it as well. There are some things about the industry right now that I'm not totally pleased with. This mass marketing or monetizing of one compound from the plant is a bit unsettling to me, but people are getting results, and so that's undeniable. However, I think if we sit back and think we're past the point of prohibition, there could be some very strict regulations coming down the line. We're all reading about the vaping. Some people have been having some negative outcomes from vaping. I think over time, as more and more people use and start to have the benefits of this, some of these issues that are currently casting a negative on the industry will subside. And it's up to myself as an alternative practitioner and my colleagues on the podium here to come up with strategies, but more importantly, results. Show effectiveness. Once you can do that, and we get to the lawmakers who are really, in the end, are going to be responsible for crafting the type of legislation that's required, then I think this will be well embraced, and at some point, the full spectrum of this plan will be incorporated into our health and well-being.
That was actually a great segue into my first question, Dr. Russell. So in this report that the federal government just released, it appears that they have done very little at this point to really address this epidemic. Now, in your opinion, why do you think it's taken so long for the FDA and the DEA to make any moves on the opioid epidemic, or even to recognize CBD or cannabis as a viable alternative?
That's directed to me. When you have a natural remedy that's been vilified and cast as no benefits in the schedule, in the way it's scheduled, I think government agencies or governmental bodies are slow to respond to what's currently happening or occurring in the industry. If you recall, some of you might recall, back in the mid to late 1800s, the British, and I went to a British school, so I know a little bit about the opium wars in China. The Chinese, it was a direct assault on the Chinese. I don't get into politics. It had to do with tea and the price of tea, etc. But they were able to slowly overcome the opioid issues there. The famous opium dens were everywhere. FDA, DEA, they're tasked with enforcing regulations. The FDA, I know there are some conflicts between pharmaceutical research coming up with evidence-based versus anecdotal results. I think in time, both the FDA and the DEA will come around. The farm bill that was passed in 2018, I didn't expect that to happen. But here we are, and look, it hasn't been a year. And if you look everywhere you turn, there's talk about CBD. It's in everything. So I think it's the masses that's going to drive the changes, not the FDA, not the DEA.
I'll add a couple points to that too. You're exactly right, Dr. Russell. I think it's the scheduling issue, which has been exceedingly slow. I think CBD has been helped with the commentary by the World Health Organization, but I think everyone is waiting for THC and its derivatives to be rescheduled, which is, I think, a pretty obvious entity. I think some of that is tied, however, with the data, which has been slow, and that's been because federal funding for THC and its derivatives have been just opened up recently, and then the THC that's used for these federal funding is from the University of Mississippi farms that everyone knows that is subpar, I think is the best way to put that. But I think there's another issue too, is that there is a tremendous amount of chronic pain population patients nationwide. So they have a very loud voice. And if you take away opioids from them, most of them will say, what else do you have? And from a physician who deals with insurance companies all day long, here's the issue, is that I can, for a chronic pain patient, I can prescribe acupuncture, which is not covered by most insurances, and that's $60 to $100 a pop. I can prescribe physical therapy, which I think is excellent, your body helping itself and everything like that, but most patients have $6,000 or $3,000 deductibles, and that's $50 a pop 3 times a week. I can prescribe interventional therapies that we can do potentially if there are issues there too. Same deductible and cost insurances come into play. Or I can give that patient morphine. I can give them 120 tablets of 30 milligram immediate release morphine, and that's probably going to be $15. So there is an economic issue that comes into play where the insurance companies are pushing still, on the TV commercials they may say we're all for better health, but when it comes down to a physician's office, what we can prescribe and what they accept and or what they don't, they are still in the archaic area of allowing and making narcotics the cheapest alternative from a pain perspective. And until that paradigm changes, there is not going to be a whole lot of change from the governmental perspective, because you have the federal government that is reducing opioids by 20% by 20 or 30% by 2022, I believe. Which is great, and there's minimization of the medicines that are getting diverted. The curves under prescribed pills that are being diverted, opioid-related hospitalizations and deaths, seem to be turning the corner to a degree. But truly, until physicians or healthcare providers have cheaper or better alternatives that are covered by insurance, I don't see it changing to a large degree at all.
So statistically, I think you kind of just brought this up. We've seen these reports where states with legal cannabis, they have witnessed maybe some dramatic even decreases in opioid prescriptions. Obviously, the story that I told, I've witnessed it myself. Can you give us, you talked a little bit in your introductions about your practice, but can you maybe talk to us a little bit about what you're seeing? Is CBD really going to be the key, or is there more to it than what we're actually, that's at the surface level?
I'll just start off by saying, yes, I absolutely do think that there is a niche, a area for CBD, CBG, CBN, the terpenes, a variety of the different cannabinoids to be used in the healthcare realm. We've seen it significantly over the last year when we've delved into it. The data shows that it is appreciable. I don't see. I guess the two things that really make me feel CBD has legs in the healthcare community is that in terms of the opioids and even non-addictive opioid medication, that research has dried up significantly, so there's not a lot of new medicines that are in phase 2 or phase 3 clinical trials now for pain medications. The existing adjuvant non-opioid pain medications that we have are equally problematic. If you look at the data from Ohio and the Midwest, like you mentioned, Dr. Shaw, gabapentin is now being a significantly abused substance on the street. This is one of our biggest adjuvant medications that we prescribed, and now people on the street have now used this at high levels to mitigate the highs and the lows. You can speak to that specifically. anti-inflammatories, there's been a rise in cardiovascular-related deaths, GI-related ulcers and hospitalizations due to increased use of anti-inflammatories, and other skeletal muscle relaxers like Soma and Flexeril and a variety of others are equally found being diverted on the street because opioid prescribing is not there. So I do think generally that CBD as a natural medication, I think there's a lot of patients now that are gearing or diverting their thoughts towards a more natural medicine, but it truly has a really negligible profile compared to a lot of the medicines that I prescribe and a lot of the adjuvant non-opioid medications that we're finding out are being abused.
Dr. Shaw, do you want to add to that?
I agree with Dr. Grove, and only add that, from my limited experience, because I do the addiction treatment, not the pain management, but I see a lot of patients coming from the pain management side, that you have different aspects of pain. I think, at least in my limited experience using CBD specifically on patients, that it has, as part of its success as an analgesic, it's probably from its anti-inflammatory component. They most likely will be able to elucidate that in a lot more detail in the future. But to me, it just makes, it's intuitive that if you have something, that one of its purported effects out of the different cannabinoids is to have pretty potent anti-inflammatory properties, and a certain aspect of pain results from inflammation, you're going to have some good results. And so I've seen patients that have co-occurring, chronic pain issues with opiate use disorder / opiate dependence, and I have to juggle, like Dr. Grove and I were talking before, a lot of these times it's not clear cut. You're not either addicted to opiates or chronic pain patient. It kind of is a gray area, and it's tough to manage in certain cases because you don't want to neglect their pain, but at the same time you got to be very careful because they have that tendency to want to abuse the opiates. So I've seen, as I've encouraged more and more patients to be able to pursue at least standard kind of sources of CBD that you can get in the market, they've reported that their pain symptoms are starting to be treated in a similar way that they would get from opiates. Because what's odd from what I do opiate replacement therapy, so using medications like methadone or Suboxone / buprenorphine. And so you're essentially chemically replacing a dependence they have to eventually titrate them off with the appropriate behavioral therapies to deal with why they have that dependence in the first place. However, there are some patients that still have very legitimate pain issues, but from my perspective, these federal treatment programs, you cannot treat pain as a symptom. And so I have to explain to them, like, look, yes, you're on a long-acting narcotic, but it's for opiate replacement. So once your withdrawal symptoms are taken care of, any, quote, pain has to be treated from a non-narcotic perspective. And that's where I see CBD, at least from my field, being very helpful.
I would chime in one more comment on that. And Dr. Shaw may have a comment on this too, but the opioid crisis that we're in right now, I have a feeling that in the next 2 to 5 years, it's going to become the benzodiazepine crisis. Xanax, Ativan, Valium, all the derivatives in that area, we're seeing a higher level of abuse. It's been coming under the radar. And with THC and CBD and the derivatives showing promise in terms of anxiety and sleep as well too, I think that CBD also has potential for medical benefit in an area of anxiety and depression that is, I believe, overly treated with benzodiazepines too, and I believe that we're going to be having some type of issue with those medicines as well.
Yeah, you're absolutely right. I forgot to mention that. I mean, CBD has tremendous anxiolytic effects too, anti-anxiety. So, as Dr. Grove said, I imagine it, and I've told people in the past, that you envision this tidal wave to kind of signify the opiate epidemic, but if you can just get on top of that wave, you're like, wow, there's another wave that might not be as substantial, but it's still coming, and it's the benzodiazepine epidemic, so to speak. I mean, a lot of the unintentional overdose deaths actually result from a combination of benzodiazepines with opiates. And up until recently, that was the majority that we would see. And when I would get patients coming in with these boatload doses of benzodiazepines that they were prescribed by their clinicians, let's just say generically, I had to titrate them down immediately and kind of hammer home with just how significant the benzodiazepine issue is and how CBD and cannabinoids will be of help in the future. Imagine a heroin addicted patient that decided to drop out of treatment because she didn't want to give up her benzos. Which one's really more addictive, right?
Agreed. I can tell you from experience, my husband will tell you that it was worse to quit the benzos than it was the opiates. So despite all of these incredible arguments that CBD has so much potential, there's very little consumer education at a national level. There's very little education, period. Obviously, we know that Israel is way ahead of us in technology. They're way ahead of us in research. How do we get policymakers and lawmakers to start putting CBD on their radar?
You know, that's a great question, because I spoke to, about 5 years ago, I met Professor Merkelam, who's from, he was credited with discovering the endocannabinoid system, which is the master controller affected by extracts from cannabis. And he told a story about how he got permission to do his research. He was trying to find some cannabis, and they said, well, why don't you go to the police? They have it. So he went down to the police station and told them what he was doing. Fortunately, they knew who he was. Some of the policemen were his former students. And they went in the back room and came out with a package, which he gladly accepted. It must have been 2 kilos. I said, why do I need this much? And so we have so much of it taken. He goes on the bus, and everyone, as he walks down the aisle, everyone is looking at him. They're smelling this skunky smell, and they try to, what the hell is this guy traveling with? Well, however, what he told me, or what he told the people in the audience, was to get policymakers to move in the direction that will benefit the end user. You have to identify specific cases, but more importantly, if you have personalities or prominent individuals who are also experiencing challenges with addiction or dependency, you get those people out because they're recognizable, their names are recognizable, and if the general public sees a positive results from these individuals, then policymakers will be more embracing to this new way of dealing with a lot of these underlying issues. And I would be remiss if I don't mention there are so many underlying causes. This is a public health crisis, but we have to look at the broad picture. What's going on in the society? The opioid crisis, in my estimation, is a reflection of what's happening in our in the world. It's chaotic. Look at the climate, what's going on. We are part of nature, and when we start separating ourselves from nature, that's when we get into trouble.
I'll add 2 comments on that too. I think for the policymakers, for this to get to that level, 2 things need to happen. I think one, unfortunately, the good and the bad of it is the CBD space needs to be a more regulated market. I think that I was on the 2018 committee for the opioid epidemic in Arizona, and it was sort of my first foray into the political landscape there too. And they are looking for, politicians love regulation, and especially with CBD, with the JAMA article 2 years ago, and I think one other article about some of the labeling of CBD. I think there's going to have to be some regulatory issues in that regard. The second issue is there's going to have to be data. My experience with the Senate Healthcare Committee in Arizona was that you're dealing with 8 guys, 6 of them may be from the construction industry, 1 may be an ex-nurse, and there's not a lot of healthcare chops in being on the healthcare committee, and not to belittle them at all, because I think they're doing very good work with a limited amount of time, but they have to rely on data. They can't just rely on anecdotal evidence, and I think that's the second reason why we need to crank out some more robust data in this regard.
Dr. Shaw, I'll actually direct this question directly to you because of your background. So clearly we still have some stigmas in the cannabis industry. There's still stigmas even though hemp has been legalized in the general population. I often hear things when I'm talking about my husband's story of saying, well, you just traded one addictive substance for another. Or we hear, but we don't know the long-term side effects. We know the long-term side effects on opiates. With all the data that we have on cannabis and all of the data here, are these really valid statements? And how do we start getting past some of these stigmas in this society with cannabis and hemp?
So these stigmas that cannabis and hemp are now facing I hear this over and over, especially the more conservative community may be that I would speak at. I think one way of addressing it is the concept of harm reduction. And we'll use my specific kind of practice as an example. I in no way would claim that opioid replacement therapy is a cure for opioid dependence, but what I would submit is that I am tremendously reducing the harm associated with that practice, whether it be unintentional overdose death, infectious disease spread, overutilization of the healthcare system, criminality. So if you look at it from those perspectives, it's much easier to kind of move past that simple, you're just trading one substance or one addiction for another. That would be probably the first way that I would address it. And then secondarily, you may be able to make an argument, I'm still kind of on the fence personally, of, in some cases, yeah, you can have some, they have recently coined the idea of, cannabis dependence, and I think in some cases that could be accurate with the idea of, lacking certain motivation. They call it amotivational syndrome. I think that's really stretching it. You could really become dependent on a lot of things. It's really, does it have a lot of adverse effects in all your capacities of life and functionality and relationships? I don't see that happening with hemp. There was a previous panel here discussing certain aspects of dosing. I don't know how many of you were part of that too, but cannabidiol has a very high ability to be dosed. It really, toxicity, I don't think is a concern in that regard. As a consequence of that and other hemp-related products, I don't think you're going to run into that. And so you can make that argument too, that whereas you could have some stigma that, well, these other medications that we're utilizing for treatments have a safety risk. There doesn't seem to be much safety risk associated with hemp-based products. Again, back to Dr. Grove's point, once they become regulated, and I'm not a big fan of regulation, but I think there needs to be some, because otherwise you're going to keep having those more dishonest manufacturers out there that could be putting anything in the bottle.
Right, and I think we see a lot of that already, so I think most of us are looking forward to some regulation.
Yeah, I agree. With the passage of the 2018 Farm Bill and CBD now legalized across the board, you have individuals who are jumping on the bandwagon. Some people that I'm aware of, they're coming from the nutraceutical industry, and they're taking that knowledge into the cannabis space, and they're encapsulating and they're making products that really should not be in the marketplace. They're just taking advantage of, the wave. And so regulations, yeah, I agree with Dr. Shaw. Too many regulations can be problematic, but at the same time, we have to be aware that there are people out there who they do not have the public's well-being at its best.
Okay, well, we have just a few minutes left, so if there's any questions that you would like to ask the panel, or if you guys have anything else that you would like to add, I would open it up at this time because we have just a couple minutes left. Back there?
First question is, opioid epidemic crisis in the United States, how much blame can you place on doctors prescribing compared to, let's say, China printing in pounds
I'll address that real quick before your next question, if there is. But no, I agree. So I think that if this was a 2000 to 2007 question, I would say 50-50. I think since many of the pill mills centered in the southeast United States and a lot of the really egregious, inappropriate prescribing had been taken out in the early part of the decade. I think since 2006, 2007, I think the most recent data I saw was from Massachusetts on the opioid-related hospitalizations and deaths, where that 87% was illicit fentanyl and heroin, and that 13% was diverted prescription pills, or a portion of that. So I think to your question, really in the last decade, since 2007, 2008, the vast majority of the issues can be attributed to China and Mexico with illicit fentanyl and the relative cheap nature of heroin compared to the sparse, true prescription pills that are getting diverted on the street now. I know you had a second question.
Test. For patients who who have a chronic illness, multiple autoimmune diseases, things like that, I do. I'm prescribed 220 MMEs, which is way above the normal. You have to give permission to have that happen. But I would, in addition to the opiates, it's also Lyrica, Cymbalta, benzos to help with serotonin syndrome, things like that. I would love to come down off a lot of that. Are you saying that CBDs can actually replace that type of a regimen? I mean, how well will CBDs be able to replace a lot of those drugs?
I can speak to the pain aspect of that. I deal with a lot of similar patients, complex. You're on 2 neuropathic agents, benzodiazepine and an opioid. I think that, and the vagueness of my answer will be that pain is a subjective science. There are patients who are on tremendous MMEs that I've seen, 800 up to 1,200, and have come down to a large portion, but a lot of that is internal, meaning that they've potentially wanted to come down. I'd be a liar to say that even at high levels of CBD, and Dr. Shaw discussed CBD at 600 milligrams a day. My 12-month data set, I think my N is 233 patients. I had patients anywhere from 25 to 200 milligrams a day of CBD, so not as high, but there was a certain correlation between patients who were on higher dose opioids needing higher dose CBD in order to reduce. So that data is there, but if you were to ask me point blank from a potency perspective, does orbital or high dose CBD get into the realm of a pure mu opioid agonist opioid in terms of pain relieving? I would say no. It is safer. I think, as Dr. Shaw had mentioned, its primary mechanism appears to be anti-inflammatory, although I do think there are some other anti-nociceptive areas that are getting teased out. But I think that if, as a patient on Lyrica, Cymbalta, an opioid, and a benzodiazepine, if you're functioning well without side effects in a certainly in an environment where those medications, the opioid and the benzodiazepine, are a little bit more difficult, I would, if you were my patient, I would have you continue. I mean, yes, 220 is higher than normal, but, you know, I'm a pain management specialist. These are the patients that we see. But if you were having side effects on those medicines, decreased testosterone, dependency, addiction, you know, uncontrolled anxiety just being on the benzodiazepines a long time, I think that that's where I would introduce something like CBD in order to minimize some of the other medications that are having intolerable side effects or dependency issues. Did that answer your question? I know it was sort of a rambling answer. Okay.
So if I could just add to that, and this is obviously this is an anecdotal story, so please take it for what it's worth. But just speaking to you from experience with my husband, when we moved to Colorado in 2016, between the two of us, we were taking 13 different prescriptions. Now, by supplementing with CBD and cannabis, but also taking into consideration an exercise regimen and diet changes, we have eliminated all 13 prescriptions. Neither one of us take prescriptions at all.
It's impressive.
I would just add to your point, especially with those that have much more of a pain symptoms secondary to a pretty significant autoimmune burden, that you're most likely going to have to supplement to some degree with opiates. However, if you can address a lot of the inflammatory-based components with alternatives, and I hear that you are, but that would be, at least from seeing patients that have been coming in on high dose, because as Dr. Grove had said earlier, sometimes, let's say the less reputable pain clinics, when the dose comes too high, they just send them over to an addiction center. And we found that in a lot of cases you can reduce the opiates, because a lot of it is subjective, again, as Dr. Grove suggested. However, I think there's going to be a lot of interest in the future of teasing out specific ratios between THC and CBD for pain management that deals with actually more the nociceptive kind of strengths that THC has traditionally has demonstrated for pain management versus maybe more of the kind of combinational anti-inflammatory aspects of pain. So it should be something that you're going to hear more of, and something to explore.
If I may add to that, what Dr. Shaw just said about introducing THC, I personally believe that we will see THC being combined with CBD. You know, this arbitrary 0.3% THC, where it's the threshold where you're the marijuana or you're hemp, you know, that coming back to regulatory bodies, that it's nonsensical to me. However, I can only go by the results and what my patients report to me. I find it's about a 60-40. The patients who end up getting their medical cards where they can now access THC, they tend to report results that are, I wouldn't say far superior, but their outcome seems to be better than those people who are only doing CBD.
Thank you. Sir, I think we're about out of time, but I think one more question?
Sure. Yeah. So I was a bit of a cowboy, I guess, and based it on the GW Pharma studies for the children with the seizure disorders, that when they dosed as high, when I was reading the publications, as high as 25 milligrams per kilo, I said, okay, at least I'm not crazy for trying an adult on 600 milligrams. But it was really, that was the basis. It was, and now I found they didn't mention, well, they did mention in the previous talk that it's tolerable up to 1,500, but there's accounts, if you comb the literature, that you can go much higher than that. Okay, so this protocol, the good news about this protocol was that started 200 milligrams, and this is pure CBD too. It's akin to, I guess, the GW tincture. It's just isolate that's resuspended in an oil. Sublingually, 200 milligrams 3 times a day. She did that for 2 months and then started titrating down. So the study only covered the first 28 days, but thereafter, she said she then went down to twice a day. So she was at 400 milligrams for another 2 months. And since April, she's been at just 200 milligrams a day, managing her symptoms. And the odd thing is, and you couldn't really do this in a research study because it would be unethical, but she ran out of product and I went on a trip for a month. And so she had no more, so you can't, I mean, the ideal study is you prove that something works and then you take it away and then the symptoms come back and you reintroduce it, but you can't do that, it's unethical. But this just happened to occur. And so she started developing certain symptoms again as pronounced as ulcerations from her Raynaud's, because she had a combination, or has a combination of lupus, Raynaud's, and why am I not thinking that? Oh, rheumatoid arthritis. So she was just hit hard with the autoimmune burden. But the good news about it is that she has not taken any other medications once starting this study up until now, and so she titrated down and she's doing well at 100 milligrams twice a day. But again, this is an N of 1, so.
Okay. Thank you very much for joining us here today.
Thank you.